Hello, I'm Dr. Edward Pearson, a hematologist in Dallas, Texas. I specialize in bone marrow and blood disorders with a focus on leukemia, lymphoma, myeloma, and the myeloproliferative neoplasms. I have a number of patients with polycythemia vera. One of the greatest threats to patients with polycythemia vera is the threat of thrombosis or blood clots. So one of our main goals is to reduce that risk of thrombosis. We do this by keeping hematocrit under very aggressive control, keeping it under 45%, as well as looking at the other cell lines, the white blood cells and platelets. In addition to treating the patient's symptoms and keeping the numbers under control, we also want to target the bone marrow. The bone marrow is the actual site of disease where the mutated hematopoietic stem cells live. BESREMi has numerous benefits that it can offer the patients in polycythemia vera, not least of which is that it is actually targeting the underlying issue within the bone marrow, the mutated hematopoietic stem cells. BESREMi is a monopegylated interferon for the treatment of polycythemia vera. It is in the NCCN guideline for the treatment of patients with PV as a first-line option.
Indication: BESREMi is indicated for the treatment of adults with polycythemia vera. Important safety information. Warning: risk of serious disorders. Interferon alpha products may cause or aggravate fatal or life-threatening neuropsychiatric, autoimmune, ischemic, and infectious disorders. Patients should be monitored closely with periodic clinical and laboratory evaluations. Therapy should be withdrawn in patients with persistently severe or worsening signs or symptoms of these conditions. In many, but not all cases, these disorders resolve after stopping therapy.
The PEGAN-VERA study was a multi-center, single-arm trial. It was conducted to evaluate the dosing, tolerability, and efficacy of BESREMi in patients with P-VERA over 7.5 years. The PEGAN-VERA trial was particularly helpful in my patients with polycythemia vera, demonstrating the ability to have disease control over the long term. In the PEGAN-VERA trial, patients were treated with BESREMi with 80% of those patients achieving a complete hematologic response. That means the patients kept their hematocrit under 45% in the absence of phlebotomy in the previous 2 months, a leukocyte count under 10, and a platelet count under 400. 61% of patients achieved comprehensive disease control, which includes that hematocrit under 45% in the absence of phlebotomy, a leukocyte count less than 10, platelet count under 400, with the additional requirements that the spleen return to normal size and there be no thromboembolic events. The median time to achieve comprehensive disease control was 7.8 months. BESREMi demonstrated a long-term, manageable safety profile in the PEGAN-VERA study. 95% of adverse reactions were grade 1 or 2, and only 5% were grade 3 or 4, including influenza-like illness, depression, diarrhea, and thrombocytopenia. The most common reported adverse reactions defined as treatment-emergent adverse events throughout the 7.5-year treatment period were influenza-like illness, arthralgia, fatigue, and pruritus. Nearly 40% of adverse events occurred in the first 3 months and diminished over time over the course of this 7.5-year trial. 0 cases of acute myeloid leukemia or AML and only 1 case of myelofibrosis or MF were observed over the 7.5 years. The PEGAN-VERA trial also presents data showing that this drug does take a little bit of time to work. It's important to coach the patients and educate them before starting on BESREMi that the drug does need an adequate amount of time to get working. The PROUD-PV trial was a phase 3 open-label trial comparing BESREMi against hydroxyurea in patients for a year. Patients who completed that trial could continue on the continuation PV trial, comparing BESREMi against hydroxyurea or best available therapy. It is important to note that there were some limitations of the continuation PV study. Initially, continuation PV was designed as a single-arm extension of PROUD-PV to evaluate the long-term safety and efficacy of BESREMi. The primary endpoint of the PROUD-PV study was a composite outcome: complete hematologic response and normal spleen size by imaging at month 12. The primary endpoint was not met. BESREMi delivered high rates of complete hematologic response in this study, with response rates of 76.8% at 3 years and 72.6% at years 5 and 6. BESREMi also delivered high phlebotomy-free rates in the PROUD/continuation PV study. This was defined as the percentage of patients with available data who required phlebotomies to maintain hematocrit below 45% for each treatment year. A post-hoc analysis of the usage of BESREMi showed an improvement in event-free survival. Less than half of the patients who were treated with BESREMi had progression of disease, a thromboembolic event, or death. I think the event-free survival data from the PROUD continuation PV trial is an important point to bring up with the patients. With all the caveats associated with the post-hoc analysis, it does appear to show a numerical difference in the events occurring in these patients with polycythemia vera. In the PROUD and continuation PV trials, BESREMi again demonstrated a manageable side effect profile. The most common adverse reactions seen at 6 years with treatment of BESREMi included decreased leukocytes, increase in the GGT, and decreased platelets. The most common treatment-emergent adverse events in the hydroxyurea and best available treatment arms at 6 years included thrombocytopenia, anemia, and leukopenia. The most common adverse reactions patients experienced in the pooled analysis with a frequency of greater than 10% were liver enzyme elevations, leukopenia, thrombocytopenia, arthralgia, myalgia, fatigue, and influenza-like illness. The LOW PV study was a phase 2, multi-center, open-label, 2-arm, parallel group, investigator-initiated, and randomized trial. This trial gave us an option for a lower dose of BESREMi that's potentially better tolerated for those younger patients who need that long-term disease control. The LOW PV trial demonstrated in low-risk polycythemia vera that 100 micrograms of BESREMi given every other week, if given adequate time to work, can reduce the need for phlebotomy and disease progression in low-risk PV. In the LOW PV study, BESREMi demonstrated disease control in low-risk patients. Compared to phlebotomy and low-dose aspirin alone, more patients in the BESREMi group achieved hematocrit control in the absence of disease progression at both 12 and 24 months. The LOW PV study also evaluated leukocyte and platelet normalization and the need for phlebotomies in low-risk PV. The leukocyte and platelet counts decreased in patients who were in the BESREMi group and for those who switched to the BESREMi group after 12 months. The number of phlebotomies per patient was lower in the BESREMi group. There were 21% fewer phlebotomies per patient in the BESREMi group than the phlebotomy and low-dose aspirin group at 24 months. In the LOW PV trial, BESREMi demonstrated a manageable adverse event profile with low rates of grade 3 or 4 events. The most common reported adverse reactions occurring in 10% or more patients treated with BESREMi on top of phlebotomy and low-dose aspirin were neutropenia, flu-like symptoms, and leukopenia. Polycythemia vera does present some very unique challenges for these patients. It is a long-term disease requiring a long-term solution. It's imperative that patients be educated on these results so that they know the importance of maintaining on BESREMi for the long term.
Indication: BESREMi is indicated for the treatment of adults with polycythemia vera. Important safety information. Warning: risk of serious disorders. Interferon alpha products may cause or aggravate fatal or life-threatening neuropsychiatric, autoimmune, ischemic, and infectious disorders. Patients should be monitored closely with periodic clinical and laboratory evaluations. Therapy should be withdrawn in patients with persistently severe or worsening signs or symptoms of these conditions. In many, but not all cases, these disorders resolve after stopping therapy. Contraindications: existence of or history of severe depression, suicidal ideation, or suicide attempt. Hypersensitivity to interferons or any inactive ingredients. Moderate or severe hepatic impairment. History or presence of active serious or untreated autoimmune disease. History of transplantation and receiving immunosuppressant agents. Warnings and precautions. Depression and suicide. Closely monitor patients for any symptoms of psychiatric disorders and, if needed, consider psychiatric consultation and treatment or dosage modifications as listed in the full prescribing information. Endocrine toxicity. Do not use BESREMi in patients with active serious or untreated endocrine disorders associated with autoimmune disease. Evaluate thyroid function in patients who develop symptoms suggestive of thyroid disease during BESREMi therapy. Discontinue BESREMi in patients who develop endocrine disorders that cannot be adequately managed during treatment with BESREMi. Cardiovascular toxicity. Patients with a history of cardiovascular disorders should be closely monitored for cardiovascular toxicity during BESREMi therapy. Avoid use of BESREMi in patients with severe or unstable cardiovascular disease or recent stroke or myocardial infarction. Decrease peripheral blood counts. Monitor complete blood counts at baseline, during titration, and every 3 to 6 months during the maintenance phase. Pancreatitis/colitis/pulmonary toxicity. Interrupt BESREMi treatment in patients with possible pancreatitis, colitis, or pulmonary toxicity and evaluate promptly. Consider discontinuation of BESREMi in patients with confirmed pancreatitis or who show signs or symptoms of serious ulcerative or hemorrhagic colitis, or who develop pulmonary infiltrates or pulmonary function impairment. Ophthalmologic toxicity. Advise patients to have eye examinations before and during treatment. Discontinue BESREMi in patients who develop new or worsening eye disorders. Hyperlipidemia/hepatotoxicity/renal toxicity. Monitor serum triglycerides, liver enzymes, hepatic function, and serum creatinine at baseline and during therapy. Avoid use of BESREMi in patients with eGFR less than 30 milliliters per minute. Discontinue BESREMi in patients with persistently marked elevated triglycerides, evidence of hepatic decompensation, or if renal impairment develops during treatment. Dental and periodontal toxicity. Patients should have good oral hygiene and regular dental examinations. Dermatologic toxicity. Consider discontinuation of BESREMi if clinically significant dermatologic toxicity occurs. Driving and operating machinery. BESREMi may impact the ability to drive and use machinery. Patients should not drive or use heavy machinery until they know how BESREMi affects their abilities. Patients who experience dizziness, somnolence, or hallucination during BESREMi therapy should avoid driving or using machinery. Embryo-fetal toxicity. Based on the mechanism of action, BESREMi can cause fetal harm when administered to a pregnant woman. Obtain a pregnancy test in females of reproductive potential prior to initiating treatment with BESREMi. Advise females of reproductive potential to use an effective method of contraception during treatment with BESREMi and for at least 8 weeks after the final dose. Advise women not to breastfeed during treatment and for 8 weeks after the final dose. Adverse reactions. The most common adverse reactions reported in greater than 40% of patients were influenza-like illness, arthralgia, fatigue, pruritus, nasopharyngitis, and musculoskeletal pain. Drug interactions. Patients on BESREMi who are receiving concomitant drugs, which are CYP450 substrates with a narrow therapeutic index, should be monitored to inform the need for dosage modification. Avoid use with myelosuppressive agents, narcotics, hypnotics, or sedatives, and monitor patients receiving the combination for effects of excessive CNS toxicity. To report suspected adverse reactions, contact Pharma Essentia at 1-800-999-2449 or FDA at 1-800-FDA-1088 or www.fda.gov/medwatch. Please see full prescribing information, including boxed warning.